As Dr. Yılmaz told us, if we have a bone defect, if our bone defect is off track, you have listened to how we calculate the on or off track lesions, you have to do a bone procedure. But if the defect is not big enough to cause and if it is on-track lesion, then in this patients you can use labrum repair techniques. Not doing a bony procedure, but labrum repair techniques can be done. But for this, you have to consider some other factors, like if the age is minimum lower than 20 years, laxity, sports, contact sports, this gives you some points. And if you have point over 6, you have to do more other than labrum repair, just bony procedures. And this is the Instability Severity Index score developed by Bolo. But if the lesion is on track, and if your point is less than 6 points, you can, these patients are candidate for labrum repair. So, first of all, before starting labrum repair, what is labrum? We have to consider what is the labrum. You know, labrum is a fibrocartilaginous tissue, but the main important part of labrum is it increases 50% of the glenoid area, contact area, and also it is the place where the ligaments are attaching. So, if there is a bone, if there is a lesion, a labrum lesion, it means that you have a ligament avulsion. This is the anterior side. In anterior side, you have the main ligament is the inferior glenohumeral ligament. You see here anterior labrum, and this is the inferior glenohumeral ligament, anterior bundle of the inferior glenohumeral ligament. This is the cadaver dissection. You see, this is the inferior glenohumeral ligament anterior bundle. It's very important. If the labrum, you see its relation with the labrum. If you have a labrum tear, this will be get lax, so causes repeated instability. This is the posterior side, and posterior side we have the posterior band of inferior glenohumeral ligament that sits here. So labrum tears of the posterior side is the avulsion of the posterior inferior glenohumeral ligaments posterior bundle. These are the places of the insertion of the ligaments. This is the inferior glenohumeral ligament, starts from the 3 o'clock to 9 o'clock, anterior bundle, axillary portion, and inferior bundle, posterior bundle. This is the place of the insertion of the middle glenohumeral ligament and superior glenohumeral ligament, and superior part from 11 to 1 o'clock is the insertion of the biceps, long head of the biceps tendon. Of course, there are some variations. You can divide the insertion points of the ligaments as a clock face, but there are some variations that it crosses that the original insertion points. So there are lots of variations. These are the variations for only 10 cadaver dissections, after 10 cadaver dissections. So there are lots of variations about the insertion points. If there are some different type of insertion points, there must be different types of glenoid tears or the glenoid avulsions. So when we consider our previous patients, we notice that there are several types of variations of the labral tears. This is because of the variations of the ligament insertions. This is the most seen labral lesion. This is slab lesion from 12 o'clock to 1 o'clock. This is the most seen variation. This is our small series about 2022, between 2022 and 2023. 955 cases with the arthroscopy. We see about 30% of them has an slab 2 lesion, and most of them is the slab 2 type. This is the insertion avulsion of the biceps tendon. In some cases, we see that the 11 o'clock goes to 3 o'clock. And these cases has real dislocations. But we know that the labrum lesions above the equator, about the 3 o'clock, there's no, we don't see any instability. But in these cases, you can see that there's an avulsion of the slab and it continues to 3 o'clock position. And in this case, you can see that the inferior glenohumeral ligament has variation. Here is the inferior glenohumeral ligament has variation, and it inserts too high than 3 o'clock. So, in these cases, inferior glenohumeral ligament also gets laxed. So, this is a variation. And also, if you look closer to your patients, you will see that there are isolated inferior labrum tears. This may be because of the instability, but most of them is because of the degeneration. So if you see inferior labrum, it may be caused by, in 50% of the cases for inferior instability, but most of them are degenerative lesions. This is the beginning of the maybe degenerative arthritis of the glenohumeral joint. But in some cases, we see both superior and inferior, isolated superior and inferior labral lesions. And this is the axillary portion. So the lesion here is constant axillary portion of the inferior glenohumeral ligament, and the superior head biceps head avulsion slab lesion. Is this any problem? This causes any problem? You can see it's inferior and superior labral lesions in here. We have published this. Sorry. Okay. We found that if there is a superior labral lesion with inferior labral lesion, this is mainly caused by trauma. So you have to repair them. Then we checked all the patients in 2 years. We found that there are lots of variations, about 22 variations of labral tear patterns. So there's not one type of tear. There are different types of tears when we consider the glenoid as a clock face. This is anterior labrum tears. The most seen is the lesion from 1 to 5 o'clock. This is the most seen 1 to 5 o'clock. And this is second most seen is 3 to 5 o'clock. And this is another type from 11 to 5 o'clock. This includes a slab lesion. Classically, we call this slab 5 lesion. These are the isolated posterior labral lesions. 55% of the lesions are only posterior side. But there is also variations on that. It can be start from 7 o'clock to 11 o'clock, or it can start from 7 o'clock to 9 o'clock, or 9 o'clock to 12 o'clock. These are variations. The most seen is this part is the most seen, is the 7 to 9 o'clock. And these are the about 40%, 42% of them are combined, anterior and posterior. So it starts from anterior, 3 o'clock, and ends to 9 o'clock. This is the avulsion of the entire inferior glenoid ligament. Anterior, axillary portion, and posterior part. And there's another variation. It starts from 1 o'clock to 9 o'clock, or it's a reverse, 3 to 9. This is 9 to 3 o'clock. So this is also seen in 2 patients in 2 years. You can see these lesions, these videos. This is an, sorry. This is another variation. It starts from 1 o'clock to 11 o'clock, 1 o'clock to 7 o'clock, 11 o'clock to 9 o'clock. And lastly, this is the other variation. It starts from 7 o'clock to 1 o'clock, and inferior that I told you before, 5 to 7 o'clock, or 360 degrees, 12 o'clock to 12 o'clock. These are seen, not uncommon, these are not uncommon, but you can see them in 5% of the cases. Apart from the location of the tears, there's a type of the tears. This is a pathology, it can be changed. Here, you can see this, the classic Bankart lesion is the periosteal avulsion with tear of the labrum, and the abscess lesion, the most seen abscess lesion, is the lesion that is more medialized after tear. These are the 2 most seen tear types. Bankart lesion with periosteal avulsion, this is instable labral tear, or medialized labrum, abscess lesion. This is the most often seen labral lesions. This is the anterior labrum tear, traumatic anterior labrum tear. Okay, the video is not working well. You can see there's a labrum tear, or anterior labrum tear, and here you can see the abscess. This is the classic Bankart lesion. You can see that the tear is avulous, but the periosteum is intact. And this is a Bankart abscess lesion. You will see when you go into the joint, you don't see any labrum, but if you look more medially, you can see that the labrum is moved medially, and it's just medial edge of the inferior medial edge of the glenoid. So if you mobilize it, you will see that the labrum comes in front of you, and you can see that now the labrum is in its place. This is the abscess lesion. And this is the posterior labrum lesion. And the most seen is the Kim lesion. The posterior part is that crack of the labrum. And here you can see the Kim lesion. If you palpate it, there will be, you can see the labrum will detached easily. This mainly doesn't cause any instability, but it causes pain. So to repair it is for pain. You can see that there's a key lesion. But in some cases, you will see the reverse of the APSA lesion. It is called POLPSA. This is the medial displacement of the posterior labrum. So you have to mobilize it before you repair it. This is the reverse of the APSA. It is a POLPSA lesion. Okay, we can classify the traumatic labrum instability or tears for anterior or posterior, or both anterior and posterior parts. So, about 50% is anterior, but the other 50% or 47% includes both anterior and posterior labrum. So, when you are going to repair a labrum, you have to be prepared to repair both anterior and posterior labrum. So you have to know the techniques to repair the anterior and posterior labrum and superior labrum together. These are the portals that you are going to use for labrum repair. We have 5 portals. The 3 portals, anterior, anterolateral, and posterior portals, are enough for you to repair anterior part of the labrum tears. But for the other posterior or posterior superior part, you have to use 2 other additional portals. These are the posterolateral or navicular portals. For this, the lesion starting from the 11 o'clock to 5 o'clock, it is enough to use 3 portals, anterior, anterolateral, and posterior portals. First of all, you have to mobilize the labrum. Now you can see we are mobilizing the labrum, and under water pressure, when you use when you artery pump, the labrum must be at the level of the granulate. So it is at the level of the granulate. You did a very good mobilization. Then you use some debridement. We don't use too much motorized shavers or burrs for debridement, not to make bony lost. Okay, just use some rasps. And after that, you have to put your anchor. The first anchor is mainly at the 5 o'clock. Okay, we start from 5 o'clock. The anchor must be put just a little bit inside the cartilage, because if you put it at the edge, the labrum goes medialized. So if you have to put it a little bit upper, just at the edge of the, like this, edge of the cartilage. Then you have to pass your sutures. As you asked before, I use lasso for the passage. You can see it's a lasso, and we pass the first suture vertically. Double-loaded anchor. This is the first suture. After first suture, we put another. We pass the other suture 2 times, one inferior, one superior. Then do a vertical suture also. This provides you more stable fixation. 1 anchor, 2 sutures, 1 vertical, and 1 horizontal. This is the you can see after repair. But if the lesion is from 6 o'clock to 11 o'clock, you have to use 2 more portals. These are posterolateral portal or 7 o'clock portal. It's called also 7 o'clock portal, or navicular portal. This is the 2 portals. Here you can see the posterolateral portal is about 4 centimeters distal to the posterolateral edge of the acromion. This provides you a good view, to insert your anchors, posterior anchors, and to pass your sutures. So this is the posterolateral anchor. In live surgery today, I am going to show you this portal. And also this is the Neviasia portal. It's coming from the superior part of the acromion. You can see it is used to pass the sutures for the fixation of the 11 o'clock labral tears. If you have the 11 o'clock labral tear, you can use Neviasia portal to pass your sutures with a spinal needle. This is an example. This is an 360 degrees of labral tear. It starts from the this is the posterior part, anterior part, inferior part. We're changing our portal. Now we are looking for the anterior portal. You can see the posterior labrum tear also. This is the posterior portal for debridement and for passage. This is the inferior portal. Anterior part, there's an outside lesion in anterior part of the, and this is the superior. We start from the 12 o'clock anchor. We start from the superior part. We repair first the slab lesion. Then this is then put another 11 o'clock anchor. Then pass the suture by using the Neviasia portal. We pass the suture from the Neviasia portal and tied it. This is the 11 o'clock suture. Then move to the inferior part, put a 6 o'clock anchor, and repair the inferior part of the labrum. First superior, then inferior. One vertical and one horizontal suture. After that, we move to the posterior cannula and put the 5 o'clock anterior anchor, and then repair the anterior part of the labrum. Always one vertical, one horizontal suture on one anchor. Double loaded anchor. Then move to the posterior side. Now we are looking from the anterior portal. You can see the posterior labrum. And then we repair posterior labrum, starting from the 7 o'clock to 9 o'clock. Then complete the 360 degrees of labrum repair. This is 9 o'clock anchor, and this is the after repair. You can see 360 degrees of repair. So we use 5 portals for this repair. Does it work? Does it work if you repair the labrum? Does it work? It seems it works if you choose good patients that have no bony defect. This is our study, this is our publication. We have 15% redislocations in multiple, after the patient has multiple dislocations. But if you operate them in the after first dislocation, the redislocation rate is about 5%. So it's important not to wait several dislocations. Operate your patients in first dislocation if the patient is younger, maybe. But if the patient is older, yes, there are also, you can also repair the labrum, and it's mainly if the patient is rotator-cuff tear, the results are more better than the isolated labral lesions. This is a sign that we have described several years ago. This is called the multiple subscapular tendon sign. When you enter the joint and look in front of the joint, you see the subscapular tendon. But in some cases, you see more than one tendon. This is, here you can see 3 tendons. Mainly the subscapulars have 4 or 6 slips. If you see more than one slip, it means that the anterior capsule is thin. If the anterior capsule is thin, then if you repair it, it will fail. So when we compare the results, if there's an outside lesion and if there's an, this is called the multiple subscapularis tendon sign, the retear rate is about 40%. So it's very, very high. So you have to choose the patients that have a good capsular structure. We collect our patients and we report our 10 years, more than 10 years follow-up patients. The dislocation rate was 20%. It's a good for the number of patients were 132 patients between 2005 and 2014 years. But we wonder if this location of the tears affects the outcomes. And we divide the location of the labrum tears, and we found that the most of the tears are between the 1 and 5 o'clock, and 11 to 5 o'clock, and 3 to 5 o'clock. The most of the patients are in this group. And when we compare them, we found that location, yes, it matters. And ABSA lesion, you know that ABSA lesion has a negative effect on repairing. And age lower than 20 years has negative effects on the results of your repair. And it even after 10 years. We found that if the lesion is between 1 and 5, the reduced dislocation rate is 2%, 2.5%. But if it is between the 11 and 5, it's about 10%. But surprisingly, if the lesion is smaller, between 3 and 5 o'clock, the reduced dislocation is about one third. 33% dislocations with the small defects. Why? Because we ask ourselves why it happens. Maybe it's smaller lesions is an isolated lesion of the inferior ligaments anterior bundle. It's a small area. It's a small contact area and has a very tension on a small contact area. And you can put lower number of anchors for this lesion because you don't have too much space to put your anchors. Also, we found that the ABSA is also negative effect, but we see that in some ABSA cases, there's also one tear, additional tear. This is a radial tear. If we have a radial tear between the at the 3 o'clock position, we found that if we have a radial tear, the redislocation levels increased. So we have another publication. It's acceptable, not publicated. We found that the overall dislocation rate for ABSA lesions is about 20%. But if you have a radial tear, it is the most of the patients have radial tears that have redislocation rate. The overall dislocation for radial tear is more than 50%. Also, the location between the 3 to 5 is also a risk factor for redislocation. So we have radial tears. If the radial tear is negative, the redislocation rate is 13%. But if we have a radial tear, the redislocation rate is 41.5%. So radial tear is very important. Why? Sorry. what to do is we have instability without bone defect. If it is 3 to 5 quadrants, if the patient's age is lower than 20 years old, we have an upside lesion or radial tear, what to do? Is it enough to do an repair or do another thing? We must think to use another technique, maybe bone block, latarjet, or remplissage. Remplissage is a good option for some of the patients, and it gives results as a bone block. So this is, you see, we have a Hill-Sachs lesion, a small Hill-Sachs lesion. You see the upside lesion here. This is our knee technique. Now we are doing this technique. You have to, you see the radial tear. When you mobilize it, before mobilization, we do a remplissage. First, we insert our anchor, then take the sutures in 2 different portals. We are ready to tie it, but not tied it. Before that, we mobilize the 3 to 5 o'clock. You see, after mobilization, there's an instability after mobilization also. You see, there's a radial tear. When you try to reduce it, and you see it goes back. So if you have an APSA and radial tear, the lesion is not stable. So we put the first anchor at 3 o'clock, not 5 o'clock, 3 o'clock, and repair the radial tear first. We put one vertical and one horizontal suture. After repairing the first, the radial tear, you see there's a continuity with the labrum. We put another anchor to the 5 o'clock and repaired it again. And then tied the sutures that we have passed before for remplissage. This is after repair. So, in patients with critical bone loss, you have to use latarjet or bone block. If the bone block is under critical level, labrum repair can be considered, but you have to be cautioned. If the lesion is 3 to 5 o'clock, if there's an APSA lesion, and if there's a radial tear, if the patient is younger than the 12 years old, maybe you need another procedure. You can do latarjet, you can do bone block, or you can add remplissage to your repair. I think next time I will give the results of these advice procedures. Thank you very much for your attention.